Good afternoon, everybody, and welcome to the Division of Interdisciplinary Palliative Care and Medicine. And this afternoon, we are hosting the noon meeting, and we are very glad to have Dr. Lindsay Farrant, who's going to present on a section of her PhD. Dr. Farrant is a senior lecturer and a senior researcher in our division. She comes with years of experience in palliative medicine and also in the research field. So welcome and thank you very much, Dr. Farrant. Dr. Farrant's going to talk to us today on a theory of change program that she held on the integration of palliative care in primary care for patients with COPD and chronic lung disease here in Cape Town. What's very nice about this research is that we're already seeing some of the outcomes of this research. So thank you, Lindsay, for really doing all this research, and it's also very good to see some of the other research team on this meeting. To Olona and Joy and Professor Liz Gwither, welcome to this, and Lindsay, we are really looking forward to this lecture. Thank you.
I'm on mute. Thanks, Renee, very much for that introduction, and thank you. Pleasure to be with you all this afternoon. I think I am going to just put my video off, if that's okay, just to leave focus on the slides. So yes, today I'm presenting on behalf of our team, the ASSET team. We've been working on this project since 2018. And the focus today is looking at the workshops, the theory of change workshops, and the outcomes from those theory of change workshops, and how we used that theory of change to design an intervention to integrate palliative care into primary care, specifically for patients with COPD and chronic lung disease. So I've mentioned all the team members here, some of us from UCT, some of us from King's College in London. And then I also want to mention specifically Professor Crick Lund, who has a position at UCT and at King's College London. At UCT, he works at the Alan J. Flisher Centre for Public Mental Health. And he was instrumental in guiding us through using the theory of change and applying it to our specific project. So I've mentioned this background when I've previously described the findings on our prevalence study, which was conducted in 2019. And really, it's just really that we know that non-communicable diseases cause the majority of deaths globally, and most of these are in low and middle income countries such as ours for various reasons. And then specifically in terms of the COPD diseases, that 2 or 3 years ago, COPD was the 4th leading cause of death globally. It's now the 3rd. And the WHO also describes COPD as being a significant contributor to disability-adjusted life years. So the impact on patients' quality of life is important to consider. And the Lancet Commission on Palliative Care and Pain Relief talked about this impact on serious health-related suffering, and that the majority of this happens in low and middle income settings. The Global Atlas for Palliative Care talks about the availability of integrated palliative care at primary healthcare level for patients with NCDs. And in upper middle income countries such as ours, only 57% of countries have a policy that includes palliative care, but only half of those have actual operational palliative care available. So there is a need to understand how we can integrate palliative care in terms of holistic care and addressing quality of life issues for such patients at the primary care level. The theoretical background for our study was really looking at how can we access and operationalize person-centered care for patients with COPD. Looking at care interventions that are really based on patient preferences, not just professionally driven. We also used the systematic review of interventions for patients with breathlessness specifically by Maddox and colleagues, published in The Lancet, and that looked at pharmacological and non-pharmacological interventions. And just recognizing specifically that patients with breathlessness from a non-malignant cause really do value guidance on self-care, as found in this publication by Farrant and colleagues. So what we did is this is a recap of what I have presented before. We looked at the prevalence of symptoms and the concerns that patients have for patients receiving primary care, or care in the primary setting at least. And then we also, so that was a quantitative arm, and then we did qualitative interviews to describe what the stakeholder views are, what the experiences of patients and caregivers are, the experiences of healthcare professionals, and how what their preferences for care would be. Together with the theoretical background that I've sketched, we then use this theory of change framework to bring together stakeholders to discuss how we could plan an intervention to integrate palliative care into standard primary care. And just as a reminder, we had this cross-sectional mixed method study. We had 8 primary healthcare sites, and we recruited 387 patients for the survey, and we had 63 qualitative interviews, roughly divided between patients, caregivers, and professionals. And so then we get to the theory of change. So this theory of change is an interesting concept, and it's something that is an iterative process, and it's considered really an outcomes-based approach, describing how a program might bring about specific changes with specific outcomes. So you might be, I see I've lost my arrows here, but if you think of yourself as being at a specific point where this ship is, wanting to end up at this X here, you've got to know what the X is and where it is and how to describe it. And you've got to describe where you currently are, and then how you're going to get from where you currently are to where you want to be. And that's essentially what theory of change aims to do in a very practical way. Okay, here are my arrows. So there isn't necessarily a specific definition of theory of change, but it could be thought of as the theory of how and why an initiative works. So quite practical. It started really developing organically. Program evaluation theorists using this method based on the theories of social change. And in the 1990s, the Aspen Institute had roundtables on community change. And out of that came this, the more formalization of this theory of change and how it might be applied. And there is now a center for the theory of change from Acknowledge. And out of this came the use of this theory of change model in research. And in thinking through complex interventions and how one frames them, how one analyzes them, the UK MRC has this framework for complex interventions. But that framework had been criticized by not fully explaining how the intervention might result in real-world change or real-world impact. So in other words, the mechanisms of change were not always clear through using that framework. And in addition, there was also no clarity on how to analyze the intervention and its interactions with the context, the specific context that it found itself in. So there were attempts to address this, and the theory of change has been applied in trying to address these gaps in this framework for complex interventions. And this paper by De Silva and colleagues of 2014 describes this, how to essentially aim at complex intervention analysis that results in an effective intervention that can be potentially sustainable and scalable because of putting in these certain aspects, looking at mechanism of change and considering the context. So from a theoretical point of view, the theory of change can be empirically tested. So I'll show you how that could look, but there are different steps that you would visually indicate and specify, and these can then be tested. In addition, the development of this theory is collaborative, involves as many stakeholders as is feasible as is possible in the specific context that you're working in. And it's also really quite flexible. So the theory can be modified during the intervention development and even the evaluation stages. So it's considered pragmatic and quite descriptive. And in addition, alongside this theory, you can use other theories to explain, for instance, why things may be occurring in that specific way. So behavioral change theories, for instance. You can also use this alongside other theories that might describe more specifically the what of the intervention. And so this theory of change model has been used quite a lot by funding organizations internationally, Gates Foundation, Comic Relief, and DFID. And they use this for monitoring, evaluation, and learning. And this quote from this review commissioned by Comic Relief is that the theory of change is an ongoing process of reflection to explore change and how it happens. And then the outcome of a workshop would be that you would visually represent the discussion, the agreement, into a map that can be a one-page map that is clearly identifying the steps that are suggested, as well as the outcome and potential impact. So it shows the pathways from where you are to where you're wanting to head, and it can be really context specific. This particular map is an example from a peer counseling for maternal depression intervention in India. And just to give you some context, theory of change workshops have been used in primary care, specifically in mental health care. And there are various projects described in the literature in South Africa, Ethiopia, Uganda, India, and Nepal. And the findings have been that it's useful to use the available evidence, so internationally available evidence, locally relevant evidence, but applying it specifically to your local setting. And so, practically speaking, a theory of change really is a process that's participatory, it's collaborative, and you are aiming at describing what you think success would look like. And in addition to that, you're going to give indicators for what you think success should look like so that it's measurable. You, at the same time, make your rationale clear, and you also describe what your assumptions are. And I'll explain that when I show our theory of change map. So essentially, you're creating a hypothesis which you can test. And so some words just to clarify. In terms of impact is a real world change, and it's not necessarily it's not necessarily within the scope of a research project to create real world change, but it is the ultimate impact that would be desired should the intervention become scalable and applied at scale. When you talk about outcomes, you're looking at what you're wanting to aim for, and you work backwards in logical steps to describe what should happen in terms of your theory so that the outcome is achieved. You describe your assumptions, which are the barriers to achieving your outcomes. I'll talk through what our assumptions were in later slides. And you look at the indicators of success, which are measurable, as I've said, and you want to also then talk through what needs to be done. So what are the actual interventions that you're going to do so that you can move from one step to the next to reach your outcome? Okay, so what did we do? So in August 2019, we had a workshop and we invited patients, family members, the Department of Health, Western Cape Department of Health. We invited our study site facility managers, family physicians, CNPs, doctors, whoever was interested in attending. We invited family physicians and respiratory physicians and palliative care physicians. And in the end, we had these participants. We had 2 patients and 2 family members, all of whom were part of our research study of the cross-sectional study in 2019. We had 1 respiratory physician, a representative from the research division in the Department of Health, Provincial Department of Health, 2 family physicians from study sites, and then palliative care physicians and our research assistants. And I have to emphasize, it was really, really helpful to have Crick Lund facilitate the workshop because he understood the process from a theory of change point of view. He's also been part of the ASSET project with his own arm of the project running. So he understood the broad objectives, and he was then able to, as an external person, see how to facilitate and lead us from where we started to the outcome that I will show you. So we had a program for the day, and Liz introduced the morning and briefly sketched palliative care for those who didn't necessarily have the context and understanding of what palliative care was and the project that we were running at the time. And I then described our intentions, the aim and objectives for the ASSET project. And then we had Professor Richard van Zyl-Smit as the respiratory physician to talk us through the COPD guidelines, South African guidelines. And I mention this specifically because it was really helpful to have that collaborative input so that we all understood what we were all on the same page, essentially. So as palliative care physician, I could understand the context and the guidelines and the positioning from a respiratory physician point of view, and likewise vice versa. So that engagement was useful, and he stayed for the discussion part of the workshop as well. So then Crick described theory of change so that all participants were clear on what it is, how it works, and how we were going to engage. And then we started with the actual engagement in terms of the questions that we were asking. And we started with what are the key challenges for palliative care for patients with COPD in primary health care. And I'm going to go to this slide. So we got into groups. The ground rules, as described explicitly by the facilitator, were that the participants at the workshop were the experts. And so it was requested that participants speak up. I think this was quite important, given that we had a very wide variety of participants, including patients and family members. And so important to consider the power differential and to ensure that all participants had an equal opportunity to voice their opinions. It was also a reminder that we had lots to discuss, so we all needed to give our views, but to be as brief as possible and not mind if the facilitator were to move on. And then the call for full participation, not having laptops while we engaged, and there was really good participation in our workshop. And then to enjoy the journey. So we had specific tasks that we had to complete, and just from a practical point of view, I'll describe the room. The room had news sheets on the wall, where headings were written as we went, and post-it notes were given to each participant to write specific keywords to indicate points that needed to be added to the discussion while we were brainstorming. These post-it notes were then presented one at a time, and by the facilitator put in under appropriate headings, if that makes sense. So I'm going to go through the challenges that were identified in small groups, just to give you the context. So some of the challenges were really practical, like transport and financial challenges. And then we got to medication issues. So the supply of pumps, the number of pumps, inhalers patients are able to receive monthly. And then stock issues, patients describing the concern with changes in the, essentially different, receiving the same inhaler, but it looked different. And not being sure whether it was the same inhaler, how to use it, whether to trust it, and so on. These were recognized by healthcare professionals as well. There was the discussion around waiting times, diagnostic ability at primary care level. And then in terms of engagement, patient and professional engagement, timing was considered. And then there was the aspect of patient education in various specific details on what education patients need, how healthcare practitioners might engage with that, communication barriers such as language barriers, and so on. And then there was the identification of lack of symptom management. So the management tending to be disease-oriented, and patients needing counseling, and then on a different level, patients needing support with smoking cessation. So a large number of varied challenges. From that, we then agreed what we thought the impact should be from this project. And this essentially is our impact statement. So we decided and agreed as a group that the impact should be that there should be best practice, evidence-based care for patients and their families through trained and equipped healthcare professionals, educating, managing and supporting patients and their families. But then the question is, how do we achieve that impact? So then looking at what are the intermediate outcomes, which are the areas that can be measured. Through discussion, we came to the conclusion that there were two specific areas, one being education of the healthcare professional for patient education and capacity building, and the other area was the area of community care. So we then broke into groups. One group looking at the education of healthcare professionals, and the specifics that were identified were these. So education on symptom management, person-centered care, holistic care, including psychosocial and spiritual care. Then looking at self-care, which might be considered pulmonary rehabilitation, but really looking at patient self-care and support of that. Items like regular annual vaccination for the influenza, smoking cessation, and then inhaler technique. So these were specified. The group working on community care agreed that there was a need for education on support in the home. So while support in the home may be available, there were often not referrals made, because it tended not to be that patients with COPD or chronic lung disease were referred for community-based care. Patients and family members talked about the need for support groups, healthcare professionals as well, actually, and community-based support groups, not necessarily only facility-based support groups. The issue of public-private partnerships was discussed, and access to home oxygen, both of which these two, it has been difficult to engage with because of the scope of our work. So we haven't necessarily been able to engage with these, but they're part of the bigger picture. So then the need for community care health worker training on various aspects of care, including smoking cessation, and then this need for engagement and care for the family, so holistic care. So out of that, all of that, the whole workshop was then summarized and concluded. And then the process was that I literally took the news sheets off the A0 news sheets off the wall, and they had their post-it notes on them, and I took them to my office, put them up in my office, and essentially mapped what is now the process map for our study. And that process map was the basis for the next slide, which is the theory of change map. And I'll go to that just to show you what the result was. So from that workshop, you can see we could create, based on evidence in the literature, based on what we were finding in our study, and on the workshop, we could design our intervention essentially. So we, on the left, you can see the buy-in. So everything with a yellow triangle is what was a study intervention, so research related. So you can see that tends to be on the left-hand side. Everything with the blue hexagon is a Department of Health intervention, so essentially considered the trained professionals engaging with the material and taking it on, showing this as really a health system strengthening intervention, not an intervention where the research team comes and does and causes the change directly. So we therefore had a number of assumptions, and the assumptions are in green. So, for instance, the assumptions were that the facilities would be committed to such an intervention. In terms of patient education, we had to assume, for instance, if we were going to do video education, we had to assume that the facilities could actually display those videos, which wasn't always the case. And then we had to also assume that the healthcare professional would use these skills and tools from the training and mentoring and apply them. So what asset interventions were we going to do? Well, we talked about getting buy-in, which is part of the research process. We talked about how needing approval and so on. And then we needed to talk about the community level, so at facility level and community level buy-in. The assets interventions in terms of creating the resources that could be used for training, and then providing the actual training. So how would that look? What is the content of the training, and what resources could we provide to the teams at the facilities to use in their care of patients? Also, just to clarify, so with the following on the training, which would be the intervention.
No, I had some.
I just want to know if anybody, maybe you could mute yourselves if you're not on mute, unless you want to ask a question. Happy to answer questions at any time, so please do interrupt. The important aspect was that the intervention was going to be training with mentoring. So the training would increase the awareness of the healthcare provider, healthcare professional, which hopefully would impact treatment and care, and result in our intermediate outcomes. So the outcomes here are what are measurable. So the intermediate outcome being increased patient-centered care, through including specific symptom management and psychosocial care, increased patient and family access to psychosocial care, increased coordination of care across sites and disciplines, and increased patient self-care and aiming at reduced emergency facility visits. And then with some long-term outcomes, but with the ceiling of accountability for the research project being this red line. So the understanding that although our impact is as per our impact statement, there is a ceiling of accountability for the research study per se. Okay, so we then used this and developed our intervention, and it essentially was training and mentoring, and we worked on the content of the training, which included basic palliative care, diagnosis and management of the COPD and chronic lung disease in line with PAC. We included smoking cessation. We included specifics on symptom control and psychosocial care. And we had a specific component on communication skills. With the inclusion of the recognition of teamwork, the referral and inclusion of community-based services, and an approach that is basically patient-centered. And then we had specific patient education topics, which were specific to including patient exercises, breathlessness interventions, self-management techniques such as breathing exercises or relaxation exercises, and then inhaler technique. So we developed material for this, specific patient leaflets, which were developed from various sources. And we also aimed at developing videos which so that they could be specific to our context, relatable for patients, and used for patient education. And we then were about to start with our intervention, with the project, which was interrupted by COVID. And so we had 2020 where we could not actually, we couldn't go ahead with our research project because of COVID. And during that time, on reflection, it became clear that it would be important to have a follow-up theory of change workshop where we could really engage with patients and families. So to get their assessment of what we were proposing. And so we did that. In June last year, we had a follow-up workshop. We were able to do that in person just before the third wave, and we essentially asked patients and family members what their perspectives were on this proposed care package that we were wanting to train professionals in. We asked them if there were any additions that they would like to make, and then we needed to act on those. So at that workshop, we were very glad to have Dr. Jenny Morgan, who is a family physician trained in palliative care and very familiar with the Department of Health and primary care setting. Sister Corrine Payne, who's been our trainer and mentor at on the ASSET project, was at the workshop, and Olona Mzimkulu, who is a social worker by training with an MPH and has been a research assistant, was very valuable in helping us with the facilitation. So we had the three of them plus me as facilitators of this theory of change, with 4 patients and 3 caregivers. And so what we did really was to present to these participants the findings of our diagnostic phase and what the theory of change process is and what the intention is. And we described what our intended impact is and described then to them what the proposed care would look like according to the training provided by our intervention. And then we asked them to unpack what gaps they had found. It was a really interesting process. And what we essentially found, these were highlighted by the group, and you can see some of them we had included in the training, but they were highlighted as significantly important to these participants. And then there was systems related items that we needed to add specifically to the training for awareness of the healthcare professionals that we trained. So I'm going to just discuss through these gaps. And the gaps that this group specifically talked through was relating to the booking system and requesting patients with advanced disease struggle to have to wait long periods of time their bookings and looking for a booking system that was manageable for both the health system and for patients, and reliable. Patients also talked through how triage could sometimes be really variable in how it was applied. Sometimes staff not being aware of the distress of breathlessness, and minimizing that, decrease and putting them in a lower triage order when patients had previously, for similar situations, been triaged as more important. And this being confusing and distressing to patients. We've talked about medication, but this was highlighted, and patients just specifically talked about wanting more information around their medication, what the medication is for, how it works, how they should take it, what the side effects might be, and so on. And patients wanted information. The discussion was that information should be in a written form, not just verbal, and requests for perhaps information and education that was media related. There was an interesting point raised in this group, which actually did come up in our in-depth interviews, was that patients don't feel appropriately assessed if they haven't been physically examined. And this was really highlighted and specifically mentioned to be put in. There was also discussion around support groups, which had been in the previous theory of change, but again, an emphasis of a need for support groups specifically in the community. And then an emphasis on the need for community health workers to be seeing these patients, supporting the families, and having the appropriate training to do so. So as a result of this second workshop, we were then able to add to the initial theory of change. And you can see in red here, I've added where we had to add specific information in terms of the education resources, but also in terms of the training that we provided. And I've added in green this emphasis on mentoring of healthcare professionals and community care workers. And that was emphasized by the participants, who I think recognized that the intended change was not just something that was a tick box exercise, that really was something that was going to require behavioral change in a way that needed mentoring. And I wasn't initially sure about adding this box, but since we've actually implemented this intervention, it's become very clear that that is a really key part of how we can integrate palliative care, is this need for mentoring. So this is slightly harder to read this slide, but this is what the same has been added to this theory of change map. And so essentially what we then needed to do was to adapt our intervention, which we did. We could adapt our manual before it was printed. We could adapt our training presentations and the approach to mentoring. So we had about 10 days to work on the manual before it needed to be printed. And our first intervention started in July, and it was over 4 weeks. So we had the facility trained for an hour per week with an additional roughly 1 hour voiceover PowerPoint presentation, which participants could access. And then we had 3 sites. It's a step wedge trial approach, and ending in the third site being trained in September, with the intervention assessment going to the end of to mid-December. So the training and mentoring content was essentially a printed manual, which all participants received. We included the primary healthcare team, the multidisciplinary team, as far as we could. We invited the medical staff, the nursing staff, physiotherapy, occupational therapy, social work, dietitian also, and the community care team managers for the teams that were managing the patients from in that facility's catchment area. And that was really quite useful to have those team members in the training. So we had virtual presentations because of COVID. We weren't allowed to be in person, which had its limitations, of course. Each facility had a Vula site, for which participants could access the electronic version of the manual and a number of extra resources. Karine managed that. And in addition, there was a mentoring approach, which used a WhatsApp group, using reminders, infographics, cases, examples of cases, case care planning, and so on. And it was a really good learning process, but there were also challenges relating to COVID because of the lack of being able to be in person. And so where we're at the moment is just getting ready to analyze the feasibility trial data so that we can appraise this theory of change and determine how correct the theory was, how inclusive the theory was, and if this theory needs further adapting. But I think ultimately what we can conclude from our experience is that this theory of change workshop format is quite accessible. And it's very useful to engage multiple stakeholders, including patients and family members. And that is very helpful for buy-in. Colleagues who in the mental health team in Cape Town have described how very useful it is to get buy-in from the senior management in the Department of Health for their research. And we would say it's certainly been very useful for us because the engagement has been multidisciplinary in the health sector, and that engagement has facilitated the intervention development and how we've thought about things. We also think it's a useful way of planning and refining an intervention in a palliative care context. And from a patient and public involvement perspective, it goes some way to engage patients and family members in an intervention planning and refinement. There's probably more one could do, but it is certainly an accessible way of engaging in PPI to some extent. So I've just got my references here. And thank you. I'm very hoping there's some questions.
Thank you, Lindsay, for a great talk. Well done, and well done to your team that's really persisted in this talk and this work, and really important work in our primary care setting to ensure COPD patients and their patients receive care. I wonder if there are any questions. Perhaps I can fire the first question and ask, there's a lot of questions coming up. Let's ask Feroza first. Feroza.
Hi, thank you. Thank you so much, Lindsay, and your team. This is such a fantastic research project and definitely much needed. So I have a comment and a question. A comment being that the reason why I say this is so important, I've personally cared for close family members with COPD, one of whom was actually in stage 4. And at that time, for me to actually access palliative care for them was extremely difficult within a primary healthcare setting, even a tertiary setting. The main treatment model was very much biomedical. And so I think this is a really great way to look at how to manage these patients from a patient perspective, which is really important. I'm also wondering, and apologies if I missed it, because it was a lot of information, did you include family members and support for family members as well?
Yeah, thanks very much, Feroza, for those comments and the question. So yes, definitely the emphasis for us was to try and engage and bring in the family member, the family caregivers into the care space. And so in our training, we were emphasizing all the time the need to engage the family member. In our cross-sectional study data, in qualitative data, there was a lot of talk of how families felt excluded and not able to access information, and so that there was an emphasis on doing that. And in the communication skills, we talked specifically about how to engage the family and how to conduct family meetings and how to break bad news and deal with emotions, to provide skills and equip healthcare professionals, because these are often barriers that we experience in trying to engage with families.
Thank you, Lindsay.
Thank you, Lindsay. Our next question is Professor Leslie London. Leslie?
So thanks very much, Lindsay. It's a really great presentation and very clear understanding. I just wonder about the method, because the diagram you had was still quite linear. In other words, A led to B led to C led to D in different permutations. But you know, in real life, things have feedback loops, and you've seen those spaghetti diagrams about causal pathways. So I'm all for theory of change, but sometimes I think it just doesn't work, because change is more complex than you can capture in a pathway like that. So I see you nodding. I don't know if you have any ideas for how to deal with that.
Yeah, this is going to be very interesting for us to analyze, because I agree. I think there's so much nuance that we've picked up on our engagement in the training and the mentoring, and in defense of the theory of change model, they do say that one can add in the other theories that might better explain why change happens or why it doesn't happen. So I think it will probably be important in our analysis to bring in the consideration of these complex interactions to better describe the interaction. Yeah, I think that's important. Thank you.
Well, good luck.
I think, Lindsay, my question is going to lead up from that. Have you noticed any soft outcomes already from this intervention?
Yes, so I think the first workshop that we had was very helpful in getting people together in the room, into one room, to discuss a difficult topic, and just to start to bridge some gaps in terms of our engagement as professionals. And I certainly have seen how understanding, for instance, the respiratory physician's perspective on how and their realities and how they're managing patients, and engaging with them, and them understanding our realities and our perspectives, has certainly bridged gaps, and has strengthened relationships, actually, so that we can work together on these challenges rather than working in silos alongside each other, possibly doing different things. So that's certainly one of the soft outcomes.
Thank you. Thank you very much. Are there any other questions? Leslie, your hand is still up. Is that an old hand or is that a new hand? Old hand. Okay. There is Magdalene. You've got a question. Maggie de Swart.
There, can you see me? Ha, good. It's really shocking that the patients really not get education on what medication they're using and how to use it and why they're using it. I just find that quite shocking, and maybe that's also why the patients were not doing that well. But I mean, these patients should have seen doctors quite frequently and the pharmacy, and like, yeah, Yeah.
Yeah, I think that's it. That is something that's been highlighted, and the lack of, the lack of patient trust in the medication sometimes, especially medication changes, and patients not really being clear on what the medication is for, perhaps, and how to use it. And from our interaction with healthcare professionals are very aware of the fact, for instance, that patients don't necessarily have the correct inhaler technique. And so emphasizing the inhaler technique is important. They're aware of that. And perhaps it comes down to how the information is provided, and how often it's provided. And so then this idea of not just verbally explaining to the patient how to do it, but the idea that written information and information via media. So the video clips, unfortunately, our video clips were not ready in time for our intervention, so we haven't really been able to assess critically how that's helpful for patients. But that was the thought, that if we change how we educate and we consider our communication approach, that might be part of the issue.
Yeah, I think important that you mention is like the videos. I think with myself as well, I sometimes forget certain things, but if I have a picture of something, I remember pictures better than just words. So if I've got a picture of which inhaler is which one, it will be easier for the patients to remember, because I think they do sometimes get the education, but because it's not written down and it's not in pictures, they can't go back, they forget, they turn them around. I think the reliever is the same as the whatever, and they turn them around and things like that. So that's quite interesting, and I can definitely use that in my teaching. Thank you very much.
Oh, great, I'm glad about that.
Thank you. I think, Lindsay, you've really, and you and your team have really touched on a very, very important aspect of healthcare. And just coming from the respiratory clinic today, it's really a real issue, and something that simple interventions can really make a huge change. Final rounds for questions. Any final rounds for questions? Okay. Lindsay, any final comments?
Thank you for the opportunity to share what we've done.
Okay. And thank you for the great presentation, and thank you for attending the Palliative Care Noon meeting. Thank you, guys.